Welcome to the Sienna Medical Partial Mastectomy Educational Video, featuring Dr. Michelle Carpenter utilizing the Savvy Scout localization system. Dr. Carpenter will demonstrate the techniques for pre-surgical planning, continuous scout guide use, and tissue control throughout the procedure for precise localization with Savvy Scout.
So this patient is an 80-year-old woman. The size of the tumor is under 1 centimeter. It's an intermediate grade invasive ductal carcinoma. The clip was placed at the time of her biopsy, and the Savvy Scout was placed earlier this week. In the medial to lateral view, it actually looks like it's in the upper outer quadrant, but in real time, it is more along the 9 o'clock position, and it is quite far laterally. And although we could use an axillary incision to do oncoplastic surgery, it wasn't in our best interest at this point to do that and keep her under anesthesia any longer than we needed to.
Prior to prepping the patient, the Scout Guide was used to pinpoint the reflector's exact location in the breast. Scout's 60mm range and real-time distance measurement within 1mm accuracy helps support the ideal incision, dissection pathway, and the depth of the anterior margin.
Because we had decided not to do the oncoplastic and skin incision, I like to actually, in the lateral part of the breast, I actually like to make a radial incision.
Before making the initial incision, the Scout Guide is used to reconfirm the depth from the skin to the reflector.
We'll inspect it again and see if it changes at all. The distance in there is a little bit closer there. So I will put another little mark on my fat where I think it is.
The Scout Guide is used immediately after the initial incision and continuously thereafter to help guide dissection and to assess the reflector's location from the surgical margin. Mobilizing the tissue where the reflector is located with a clamp or suture allows the surgeon to retract tissue to allow for repositioning the Scout Guide, using the distance measurement to assess each surgical margin throughout the dissection.
It looks like it's a little closer to the inferior. It looks a little farther from the superior. And it's about the same distance from the lateral. So at this point, it looks like I'm a little bit more on the lateral and inferior side of that mark. So I just move over there a little bit more. It still says I'm far away. I'm getting closer, but now if I think that I'm distorting the tissue for margins, I will put it back in and I will actually add a stitch so that I don't have distortion when I take it out, because a lot of times I'm going to be pulling it up at different levels. So I'm going to put a stitch where I believe the superior margin is, which is my normal markings, so you use whatever normal markings that you would use. And I still haven't taken my lateral margin, and it looks like I can come down here. So as I start to lift it off of the breast, I come underneath it and it looks like I'm doing okay. Some of us have been trained to go down to the fascia. If you are, you can go down to the fascia at this point. If I think I'm getting in a little close, I check it again. And each of those times I was at least 5 millimeters away, which is a nice distance. So now I have my specimen, and I like to get my markings done before I start checking it again. You can do a quick little check to make sure it's there. So what we have here, we're looking from the skin posteriorly. We have the Savvy Scout right there. The previous clip is right there. We had a problem with getting on-time case starts because there would be a problem in radiology for needle localizations. We also have our breast center in a different building. And we would literally take our patients, because of our medical legal issues that we have, and put them into a little cart or an ambulance and then transport them to either our surgery center or the hospital. Transitioning from one case to another, if there was a delay in radiology, our flow in the operating room was not very good. Sometimes the way the schedule is in the breast center, we would have a localization scheduled at 8 o'clock in the morning, and the case wasn't scheduled till 2 in the afternoon. And the patient's asking us, why did you schedule that so early? And it was more just a schedule. It had nothing to do with what we needed to do or what we had to do. And so there they were, sitting with a wire in their breast, bandaged up, most of the time not hurting, but sometimes not very comfortable, and they were here all day and they didn't have to be. When it's time to schedule an operation that requires localization, using the Savvy Scout is so much better in terms of scheduling, turnover, and on-time starts. We started to realize the advantages of wireless technology, especially in a patient who's getting chemotherapy. If you give patients chemotherapy, you know you're not going to be doing the operation for minimum 3 to 4, sometimes 6, 8 months later, and especially if you're doing hormonal therapy. So when it became known that we now had an unlimited time period to have the Savvy Scout placed, I did have very good experience in having it placed in neoadjuvant patients, especially in the axilla. And the reason for that is that it is a very important part of the patient who has a positive lymph node who has had neoadjuvant chemotherapy. If we believe, and we have imaging criteria that shows that that node now looks normal, we can actually go in and do a sentinel node and remove the clipped node. In the past, sometimes those nodes were inaccessible with just a small clip. They were inaccessible because we couldn't get them into the field, or whatever clip was used was not seen by ultrasound, which was one of the ways in which we could find it, to get it localized, to be able to remove it. So having Savvy Scout made my life so much better, because all I had to do was bring my Savvy Scout localizing probe into the operating room, and it was just wonderful.